Hello, I'd like to thank Vumedi for inviting me to discuss today the art and science of genetic counseling in nephrology based on a recent review published in Kidney 360. So really the goal of today for me is to go over genetic counseling for nephrologists just to make sure that it's not some dark science that nephrologists don't feel comfortable referring their patients to. Genetic testing should really be just one more tool in nephrologists' toolboxes, and like nephrologists are used to talk with pathologists and with other people from different specializations. You should be familiar and feel comfortable talking with genetic counselors. So my name is Hila Milo Rasouly. I'm an assistant professor at Columbia University Irving Medical Center, and I'm the Associate Director of Education in the Center of Precision Medicine and Genomics. So first, let's talk about the indications for genetic counseling or genetic testing. We're calling them red flags. These are the indications that really make sense, I think, in an intuitive way for nephrologists. If you have an unusual clinical course, you have family history of kidney disease, you have extrarenal involvement, or it's a kidney disease subtype which is known to be associated with genetic, like polycystic kidney disease, or you have a concern for specific genetic conditions, then you should discuss with your patient the option of either referring them directly to genetic test or referring them to a genetic counselor. And so these are some of the questions that we put in a table in our review of how to ask your patient about personal history or family history that would indicate there is a reason to refer to genetic counseling or testing. And I think this is really important to have in mind, maybe to even print out this table so you can think about these questions and ask them when you are seeing a new patient or a patient that you've seen for a while but never discussed genetic testing with them. You also have to remember that the motivations to genetic testing are not always overlapping between the patient and the provider. So you may think, well, I already know what is the diagnosis of my patient. For instance, they have clearly, based on family history and everything, they have autosomal dominant polycystic kidney disease. But for the patient, it might be important to know the specific genetic variant. It might allow them access to reproductive planning options, which they cannot use if they don't have a genetic diagnosis. It can help them determine the risk of family members. And nowadays, with the new genes identifying for PKD, for example, it can really inform the prognosis in a different way than it used to be. So keep in mind that while elucidating the disease diagnosis is one of the goals of genetic testing, it's not the only goal. And thinking of how genetic testing could be relevant for your patient is important. So we created a figure in our review about how pre-test counseling should look like. So it obviously starts with medical history, and we have here some examples in the clouds of questions that you may want to ask your patient, or you may want to ask yourself. So you may want to ask yourself, what is the most likely clinical diagnosis? Or does the patient have non-renal disorders? And then go back to the table I just showed you and think of how you ask this question to your patient. You want to collect information of 3 generations from your patient back. And that's important because sometimes genetic diseases are X-linked, so they will skip females, or they are dominant but with incomplete penetrance, and not everybody will have the same presentation. As a genetic counselor, I would recommend drawing a pedigree, but obviously you don't have to. You can also just refer your patient to genetic counseling. Think about what is the etiology, what what could be the reason for your patient to have the disease. And even if it's not relevant for your patient care, it might be important for your patient psychologically to understand why they develop this disease, and it definitely can help guide genetic testing. And finally, a pre-test counseling ends up with an informed consent where you discuss the benefits and the risks of genetic testing with your patient. Now, all that can be done by you, the nephrologist, or by the genetic counselor to whom you will refer your patient. So we created a table also for those of you who feel like, well, I can order the test myself, but I'm not always sure how to read the results. So this is a table just describing the explanation that how you will explain the test to your patient, discuss the pro and the cons, the potential implications, and again, we added here questions to open the conversation with your patient. We also have a figure describing the post-test counseling. If you are the one who ordered the test, then you would be doing that. If the genetic counselor ordered the test, then the genetic counselor would do that. And it starts with result interpretation that is actually done prior to meeting with the patient, and continues into clinical integration. Think of how these results integrate with all the rest of the things known about this patient, how can it potentially impact your patient care, or maybe allow your patient to have access to clinical trials. And then finally, when meeting with the patient, really providing the psychosocial support to understand the results and understand what's next. We added a table that covers the different parts of the genetic report. And I think that's important just to highlight the fact that the genetic report includes all the information. So there is often not real need to go online and do a lot of research because the report includes that. But it's a long report. It's often more than 5 pages. And so it might be worth to be familiar with the order of the test and where to find things that might be of interest for you. We also included in the review a reminder of inheritance patterns and remind you that while you learn the inheritance pattern in a very specific way in school, the most common forms do not look like what we are seeing in school. So while autosomal recessive was taught to us often being associated with consanguinity or having multiple kids with the same disease, sometimes it's actually just one kid, right, that has the disease, and it looks like it's de novo, but it's actually recessive. Autosomal dominant, we learned that it's every generation, but often, again, it can look at just one person because it's de novo, it only happened in this kid, or because it's in incomplete penetrance. And similarly, X-linked, we learned certain patterns, but often it looks a little bit different. So we also created a flow diagram in the review to guide you through how to plan the return of a genetic result. First of all, differentiate between positive and negative result, and then under positive result, differentiating between a diagnostic finding, an incidental or secondary finding, or a risk factor. And on the negative result side, we differentiated between there is no report of any variant of interest and there is a candidate diagnostic result, a VUS in a gene of interest, and what to do at each step, including always the baseline suspicion that you may have. Maybe to begin with, you thought that the chance that it's genetic is pretty low. So if there is no report of variant, then there is really no need for further testing. But if you thought that there is a really high chance that this patient has a genetic cause for their kidney disease, and you only found an incidental or secondary finding, then there might be a need to rethink the test sensitivity, specificity, and maybe refer to other genetic tests. Now, I think that in these cases of a high suspicion but no diagnostic finding, really referring to a genetic counselor is the best next thing to do. We also offer a table of how we reclassify variants of uncertain significance, VUSs. Again, this is maybe for more advanced nephrologists to feel really comfortable taking it this one step further, but it's also just for any nephrologist to understand how do genetic counselors think, what are the type of questions that they are going to ask you. They will probably ask you for help to collect samples from the parents or to get more clinical information if really the goal is to understand more the clinical overlap. Most importantly, we added in the review a table of resources, and we put a question of what type of questions these websites can answer. For instance, when should I refer a patient to testing? Or there is a term I don't understand. What does it mean? What is this disease? Where can I find these answers? And so we have here a list of really useful websites that I encourage you again to potentially print out and have them close to you so you don't have to search for them each time. So in conclusion, I would suggest that every nephrologist will know how to reach out to a genetic counselor. In the United States, we have a Find a Genetic Counselor website that was created by the National Society of Genetic Counselors. Really something handy to have. You can search there for genetic counselors with a specialization in nephrology. Genetic counseling is often done today as telemedicine, so really where the genetic counselor is doesn't matter as much. And there are more genetic counselors out there than you would think, and they would love to see your patients. Thank you.